Good evening, everybody, and thank you so much for joining us for this evening's webinar on lifestyle medicine. Really excited to be presenting this webinar to you tonight with two fantastic colleagues. There's a real buzz around lifestyle medicine at the moment, and I know lots of people really hungry to know a bit more, to understand a bit more about it, and that's what we'll be hoping to do for you over the next hour. Most of you, many of you will have met me before, I'm sure, on various webinars, courses or whatever. But if you haven't met me before, it's an absolute pleasure to meet you, albeit I'm sitting on your kitchen table and a laptop at the moment. But it's a pleasure to be with you. My name's Simon Curtis, and I'm a GP based in Oxford. And I'll be leading the webinar for you this evening with my two fantastic colleagues. First up is Will in Exeter, who's going to be fielding all your questions and comments on the Q&A chat. Good evening, Will.
Good evening, Simon, and good evening to you at home. I'm so excited that so many of you could join us for this important topic. Lifestyle medicine, it's, as Simon says, it is the thing of the moment. And I want to know in the Q&A, is this something that you're doing already in your practice? Are you completely new to this? Or perhaps you're even a skeptic and you're not entirely convinced. Whatever your thoughts, comments, or questions, please send them over to me in the Q&A. I absolutely love hearing from you. And if it all gets a bit much at any point, there is a really nicely put together supplement, which you can find in the resources section at the bottom of your console. So you download that. That's got a great summary of everything we're going to talk about this evening. So looking forward to interacting with you. In the meantime, Simon, back to you.
Okay, thanks very much, Will. Do keep Will busy with your comments and questions and things that are coming in. And then at the end of each section, we'll be discussing some of those questions and comments with our guest speaker this evening. So I'm absolutely delighted that this evening we're going to be joined by Camille Hirons. So Camille is a GP, NHS GP in North Lewisham. She's the PCN lead for health inequalities in her area, which I think is really, really crucial because this whole topic or issue of lifestyle medicine really ties in importantly with health inequalities. She's also a certified lifestyle medicine physician, and she's the clinical lead for the North Lewisham Lifestyle Medicine Service, which she set up. So good evening to you, Camille.
Hello, everyone. Thank you so much for inviting me along to speak today, Simon and Will. I'm really, really pleased to be here, and hopefully it will be interesting for some of you, and you'll be interested to practice some lifestyle medicine, hopefully.
And Camille, just tell us what inspired you to want to get into lifestyle medicine and become a certified lifestyle medicine practitioner? What was the big step that made you want to do that?
I think I was interested in lifestyle medicine way before I realized it was called lifestyle medicine. And I think it really stemmed from frustrations that I felt as a doctor dealing with patients. So I would follow guidelines, I'd be prescribing medications, but yet those people would still come back to me and still have the same problem, and I wasn't really fixing it. So lifestyle medicine seemed like a solution to try and deal with some of those root causes and also empower patients to be less reliant on the health service. So that's kind of where I've become interested in it.
Fantastic. And I think we can certainly all relate to that. So thank you very much, Camille. And we'll be talking to Camille and hearing from Camille a little bit later on in the webinar. But of course, following the sort of very tragic death of Michael Mosley over the weekend, it would be impossible not to have a webinar on lifestyle medicine without mentioning his incredible life and work and the sort of contribution he's made. And certainly I've had many, many patients over the last 10 or 12 years who've really picked up and sort of followed on his advice. He had this real ability to communicate with people in a way that sort of really resonated and that they really understood. And I think particularly his idea or his notion of just having very little habits, making small incremental changes that can have a big impact on a patient's health are really significant. So he'll be hugely missed. He leaves a tremendous legacy, and all our thoughts, of course, go to his wife and family at this time. So what's our plan for this evening? Well, we'll split the webinar into two, and we've only got an hour, and this is a really big complex topic. So we're going to, in typical MB fashion, keep it really simple and just give an overview of what lifestyle medicine is about. First up, I'm going to do part one. Think, why have we got this buzz around lifestyle medicine? Why do we need it? What do we actually mean by it? What it is, what it isn't, a little bit of the evidence base as well. Then we'll discuss with Will and Camille some of the questions and themes that have come out of that. And then in part two, Camille will be talking about the 6 pillars that you may have heard of that underpin lifestyle medicine. And importantly, how you can effectively deliver lifestyle medicine in NHS primary care. None of us have got any time. We all seem completely strapped for time. How can we do this practically? And also at an organizational level, how on earth has Camille managed to introduce a lifestyle medicine service in her PCN? I'm sure we'd all love to hear that. And then we'll have a look at some further resources as well. So first up, why this sort of big buzz about lifestyle medicine at the moment? Well, there's a lot going on within the medical community. There's a diploma in lifestyle medicine, which Camille has done, and a number of other GPs expressing an interest in this as well, which is accredited by the British Society of Lifestyle Medicine. If you've never heard of them or come across them, it's really worthwhile exploring their website. But lifestyle medicine is also being introduced into medical school curricula. God, when I was at medical school, there was never any mention of any lifestyle factors whatsoever. But it's now a key part of medical school curricula, and Cambridge University, Imperial College are just 2 examples of medical schools which now have programs in lifestyle medicine. And as with Camille being a real flag bearer for this, lifestyle medicine services are now being introduced into the NHS. And the RCGP are now starting to introduce GPs with extended roles in lifestyle medicine. So if this is something that you're really interested in, you can become a GP with an extended role in lifestyle medicine. So why do we need lifestyle medicine? And I think when I was reflecting on this question, when I was out on a walk preparing this webinar, this patient sprang to my mind, Gary. I'm calling him Gary. That's obviously not really Gary, but let's call him Gary. I've had so many patients like Gary. And he's a taxi driver, divorced, he lives alone. He eats poorly. He drinks a bit too much. And he's coming to see me saying that he feels tired all the time. He's got multi-morbidity. He's had depression. Didn't react well to SSRIs, sleeping poorly, so I've prescribed mirtazapine, which has not been great for his weight gain. He's got high blood pressure. I've got him on losartan and thiazide. He's got raised triglycerides and LDL. I've got him on a statin. He comes to see me with gout. I prescribe allopurinol. He's complaining about erectile dysfunction. I prescribe him sildenafil. And after he leaves at this conversation, I'm just left there scratching my head thinking, surely I could be doing better for Gary than just serially prescribing all of these different drugs for all of these different conditions. And the other reason why we need lifestyle medicine looking at a bigger picture, going more macro, is just this staggering data from the World Health Organization that chronic diseases, non-communicable diseases, are responsible for 75% of all deaths globally. That's not a surprise. But 40% of these deaths are premature before the age of 70. And 80% of those are attributable to just 3 risk factors: smoking, poor diet, and lack of physical activity. And as we were saying at the beginning, crucially strongly linked with socioeconomic inequalities. And we see this, don't we, all the time in our practices, that huge socioeconomic gradient in health, which is why lifestyle medicine is such a crucial topic for trying to narrow and close that gap. But it's not just people dying earlier, it's people also being iller and sicker and on more medications for longer. People are spending a much greater proportion of their lives in ill health. And one of the messages which we want to put across is a sort of positive message of not just avoiding death and disease, but just feeling better and feeling healthier, expending the period of your life where you're independent and able to do stuff and enjoy it. In other words, your health span as well as your lifespan. And as has been highlighted in a recent BMJ just last month, this is a real problem here in the UK at the moment. It says among European countries, the UK is a relatively poor, sick country with some rich, healthy people in it. But in the UK, our global ranking for life expectancy is falling. It plateaued a while ago and is falling. Only the US is faring worse. And that life expectancy and healthy life expectancy are really closely linked to deprivation. And that's the thing which we've really got to try and close. And there are lots of things that we can do to try and close that gap. And a recent report in the King's Fund saying to do that, it's particularly cardiovascular risk factors that we need to focus on, because it's responsible for a quarter of all deaths of the UK, largest cause of premature mortality. And it's been highlighted as the single biggest area where we can save lives and improve health at an earlier stage and narrow out these health inequalities. People in England's most deprived areas are 4 times more likely to die of premature heart disease, and up to 80% of these premature deaths are preventable. So there is a lot that we can do. And lastly, the other reason we really need to think about lifestyle medicine is the alarming rise of sort of chronic diseases amongst younger people, younger adults, people being diagnosed with diabetes, hypertension at an earlier and earlier stage. So that's why we need it. But what do we actually mean by lifestyle medicine? Well, of course, medical care is very much focused downstream on managing all the long-term complications of diseases, like my patient with dyslipidemia, hypertension, erectile dysfunction, gout, etc. And it operates in silos. And we see this in hospitals where there's a hypertension clinic, a diabetes clinic, etc., etc. And in general practice, these silos exist in the form of single disease guidelines, algorithms that we follow, which are all just looking at the long-term complications, whereas lifestyle medicine is aiming to look upstream, looking at the root causes and holistically with the individual patient. So there are lots of different definitions for lifestyle medicine, but I think the simplest one is the use of evidence-based lifestyle therapeutic interventions to try to treat and reverse chronic diseases. So helping people to understand the upstream determinants of their health and chronic disease, and then to create the environment to enable change with behavior change skills, and then to support and sustain, to support people to then make and sustain changes. But to be effective, it requires patient engagement and a multidisciplinary, multi-system approach. There are 3 underlying principles of lifestyle medicine: understanding the socioeconomic determinants of health in the context of the patient, providing skills to support people to make sustainable changes, and Camille will be talking about some of these skills, and then knowledge of the 6 pillars of lifestyle change, which you may well have heard of. And although they're called 6 pillars, I actually prefer to think of them as spokes in a wheel that's sort of rotating around a hub, and that hub at the center is you, because they all interconnect in a positive feedback loop, and also conversely in a negative feedback loop. And I look at times in my life when I felt bit sad or low or sort of depressed, then during those times, I'd be more likely to eat poorly, eat bad food. I'd be more likely to drink more. I'd be less motivated to sort of exercise or meet up with friends or socially connect. As a result of all that, I wouldn't be sleeping as well. And that then just spirals down. But similarly, if we can improve our mental well-being, our social connection, or just make one of these small sorts of changes, then that can just start to spin the wheel in another positive direction. And Camille will talk in part 2 a little bit more about each one of these pillars. So there are a lot of myths around about lifestyle medicine, and I think it's worth busting a few of these myths. And one that I've heard a lot of over the last month when I've been preparing this is, well, lifestyle medicine's just for the healthy, educated, well. It's just for fit, well people who are just getting even fitter and weller. And of course, lifestyle medicine is for absolutely everybody. But of course, our absolute priority has to be the people in the greatest need to try to narrow down those health inequalities. And this is something which the British Society of Lifestyle Medicine explicitly addresses, looking at poverty and health inequality. Another thing you commonly hear is, well, it's just a form of complementary, alternative, non-evidence-based medicine. At worst, it's just really quacky. At best, it's just very, very fluffy. And this quote from the Royal College of GPs saying it's a globally recognized medical discipline internationally with a strong evidence base and widespread practice. People often say, well, it's the emperor's new clothes. We've always given healthy lifestyle advice. And that is true. But what we now know from very good sort of behavioral research is that just giving simple top-down advice, particularly from a position of sort of health and privilege, then is often just ineffective. It does not work. We need to sort of consider the wider factors contributing to people's health using a person-centered approach, and to use proven techniques such as motivational interviewing, for example, which will brief interventions, which we shall discuss, to make sustainable changes. And often it's thought, well, lifestyle medicine is just about eating less and moving more, but all of those pillars are critically important, and none of those will be effective unless we can really address emotional well-being and stress reduction, finding purpose in life, to have that motivation to make these other changes, and social connection are similarly important. We can't look at these things in isolation. And lastly, and I think perhaps most importantly, there's often a fear amongst doctors that lifestyle medicine, or discussing lifestyle medicine, will just blame the patient for their problems and then just set them up to fail. It's absolutely not about blame and shame. It's about understanding people's context and values, about understanding their readiness for change, and then working with them to create an environment where change may be possible, when or if they're ready to do so, and based very much on realistic goal setting. Giving agency and autonomy to the patients. So where's the evidence then? Well, sounds great, doesn't it? But where's the actual evidence that it's effective? And of course, there are multiple long-term studies. The CHIP program, the Complete Health Improvement Program, has been publishing huge amounts of research on this over many, many years. We've got the link to that in the resources, published numerous papers showing the efficacy of lifestyle medicine approaches. A classic trial, the Lifestyle Heart Trial by Dean Ornish et al. Dean Ornish was a real pioneer in lifestyle medicine. It's a classic study showing that in patients with severe coronary heart disease after a major heart attack, to undertaking a sort of multiple-pronged lifestyle medicine approach with significant changes in diet and exercise regime, leads to a regression of their atherosclerosis and halves the risk of recurrent events compared to usual care before you've even prescribed a drug. Those of you who've been on Hot Topics GP update courses over the years will have heard me talking before about the DASH diet studies for hypertension, the dietary approaches to stop hypertension studies from the US, which show dietary changes can be as effective as drug interventions for treating hypertension. And there are a whole load of all of these other studies as well, diabetes prevention program, multiple risk factor intervention trial as well. And a couple of specific ones that I think worth highlighting was this systematic review of 20 studies, 500,000 people with 13 years of follow-up. So a really good bill of data showing that 4 or more healthy lifestyle factors were associated with significant reduction in morbidity. And this recent study, which was picked up by the National Institute for Health and Care Research, published one of these alerts about this in the BMJ, showing in patients with multimorbidity, which most of our patients have, a lifestyle medicine approach combining exercise, diet, avoiding smoking and excess alcohol could increase life expectancy by up to 7 years, as well as improving general health and well-being. Okay, over to you, Will. First up, Will, is anyone out there? Have we had any questions or comments coming in on the chat? Tell us what's going on.
Oh, they certainly are, Simon. There's a real buzz in the Q&A, and it's so interesting to see many of you at different stages. So, for example, some of you are, this is completely new. So Sarah's saying it's completely new to you, this whole thing of lifestyle medicine. Right up to, we've actually, Simon, we've got the founding member and founding regional board director of the British Society of Lifestyle Medicine on the webinar tonight. So people completely new to people who've been doing this for a long time. And there's just a real positive energy in the Q&A around this topic. And we, many of us in this webinar, we're all jobbing GPs. And the other theme that's coming out here, Simon, is the myriad barriers to actually implementing this in real day-to-day general practice. So Sumita reflecting on how we just would love to have longer appointments to really try and implement some of these great ideas. And other things, another common theme that's coming up is how do you engage patients, many of whom have this expectation that they will be prescribed something for their ailment. And actually having these conversations around lifestyle is a lot more time consuming, and you really do need patients buy-in. And just linked to that, there's a really good question that's coming up around resources that help support that conversation. So tangible things we can share with patients to support the kind of lifestyle and behavior change. And actually, this is just a moment I wanted to bring Cami in on this question. So there's 2 parts there, Cami. First of all, how can we achieve the buy-in of patients who have that pre-existing expectation they'll be prescribed something? How do we not prescribe? And what are your top 3 resources that we can share with this audience that will help them to have that conversation with their patients?
Sure. Well, I don't have all the answers, but from my experience when I've been chatting with patients, actually, I felt a lot of the resistance was internal. I thought, they're not going to be interested in lifestyle. They'll want something. But whenever I've asked, patients have always been interested in the lifestyle change. They've always been interested in how they can help themselves. Yes, there are sometimes barriers, and I'm very aware of that. But often it's the patients that are interested and keen. So I will often phrase things like, there are medications, that is an option. However, if we're trying to deal with the root cause, rather than just stick a plaster on it, then we might want to think about a behavior change. But we'll go on to how ready people are to change in a bit, and hopefully that might give you a few more kind of answers there. And I think the second part of your question was about my favourite resources, was it, Will?
Sure.
There are loads. And I think it depends on the patient in front of you. I love listening to podcasts, but my nephew told me that no one under the age of 30 does that. So I'm not sure that podcasts are always the best format to share. But the American Society of Lifestyle Medicine, the British Society of Lifestyle Medicine, they both have excellent patient handouts that are really good. The British Dietetics Society have got some wonderful things. And then it really depends. Doctor's Kitchen have done more than 3, but depending on the pillar you're trying to share, there are some really lovely patient handouts. And one final one, Jack Munro. I work in an area of deprivation, and she does excellent, really, really cheap but healthful recipes. So that's a really good one. Living on a shoestring, I think, or a bootstring. I'll look it up in a second.
Yeah, and I will share those suggestions in the Q&A in a moment, so you can load them up, bookmark them. But yeah, it's really good to have something tangible to give to patients. I think another key theme or barrier that's coming out is really the limitations of what we can achieve in at practice level. And some people have reflected on how we live in a society that unfortunately promotes unhealthy behaviors and lifestyles. And it can sometimes feel like a thankless task when all around us, you see how society is run. And we can't always change that at a higher societal and political level. But I think as health practitioners, we're all here to do the best we can with what we've got. And then the final thing I wanted to ask you, Camille, just quickly before we go back to Simon, and this is another really hot topic in the Q&A. Lots of people here, lots of clinicians are keen to get more accreditation, perhaps through the British Society of Lifestyle Medicine or with the RCGP. Could you briefly reflect on what your route was in getting that extra training? And someone that's perhaps new to this area that wants to upskill, what's the best way for them to approach that?
Absolutely, yeah, happy to. So I did my diploma in lifestyle medicine, so to become a certified lifestyle medicine physician in 2021. I actually did it when I was working 10 sessions as a GP, and I did it in about 2 months. It was quite a lot of work, so I would recommend giving yourself a bit more time than that, but it is very possible, is what I was trying to illustrate there. At that time, British Society of Lifestyle Medicine didn't have a core accreditation, so I had to do it via the American Society, and the British Society did the exam part. But it's the same thing, essentially. Now BSLM do their own core accreditation, so I'd encourage people to have a look if they're interested. If you're not sure, another option, for example, I think on BSLM they have a Foundations in Lifestyle Medicine course. Much cheaper, much shorter, and it just gives you some more of that basic knowledge that might be interesting to see. Is this something you really, really want to learn more about? But there are, of course, other routes. I haven't done the RCGP one, prescribing lifestyle medicine. I think it's a bit shorter, but there are lots of routes to kind of develop your knowledge and your skills.
Fabulous. That's some really sound advice. I think what we'll do now, Camille, we'll move on to the second part of the webinar, where you're going to tell us about an amazing piece of work you've been doing in Lewisham. Over to you.
Lovely. Well, thank you. Before I get on to the work I've done in Lewisham, I'm just going to tell a bit more detail about those 6 pillars of lifestyle medicine. And then we're going to go back to Gary and think about how we might be able to deliver a lifestyle medicine approach at an individual level with Gary in the room, but also maybe at an organizational level. And I'll tell you about my lifestyle medicine service that I have set up. Okay, so if we think about the 6 pillars of lifestyle medicine, I think in our current guidelines and our current kind of health systems really do recognize nutrition, physical activity, avoiding smoking and alcohol. It won't come as any surprise that, those things are important. But I think it's the detail that we are lacking, and also some of those other pillars sometimes seem to be a bit forgotten. So I'm going to start with nutrition. So lifestyle medicine advocates for a whole food, predominantly plant-based eating pattern. Now, that does not mean that you need to be vegan, and it doesn't mean you have to be vegetarian. It doesn't talk about a specific diet. It recognizes the evidence behind multiple diets. But the thing it does, it doesn't focus on macronutrients, so protein and carbs. It focuses on more the whole food. And by doing that, you're minimizing ultra-processed food and you're minimizing excess sugars as well. So it compares lots of data, lots of studies when it talks about nutrition, and also some of the data from the blue zones. If you're not aware of the blue zones, those are the 5 areas that have the healthiest populations, where the people live the longest across the world. Very interesting, and I do encourage you to read more if you don't know about them. Moving on to the next pillar. So we have physical activity. So with regards to physical activity, lifestyle medicine advocates the same kind of quantity of physical activity that we see within our national guidelines in minutes per week. However, it goes into more detail on the types of exercise or physical activity. So it might talk about aerobic exercise, strength, flexibility, and balance. And some of the evidence is really interesting around there. For example, elderly patients who work on their balance and flexibility have a reduction in injury and a reduction in falls whenever they've been falling. They've had a reduced severity of falls, need for medical attention, and a reduction in neck and femur fractures. So some really interesting stuff around physical activity. Moving on to reducing our risky behaviours. So that can sometimes be seen as more of the negative pillar of lifestyle medicine. And that's because we're often referring to eliminating things rather than adding things or adding things that are positive. And as I've said already, I think most of us would know already, alcohol, smoking, and recreational drugs can cause a lot of harm to our health and our well-being. But lifestyle medicine sometimes goes a bit further than that, and it talks about other behaviours such as excess internet use, social media use, and even gambling. If we move on to mental health, lifestyle medicine supports the use of non-pharmaceutical, lifestyle-first interventions with regards to mental health. And that's in prevention and treatment of mental health conditions. It does, of course, recognise in severe mental illness the role for medication. But it does also talk about things like purpose, giving patients meaning, patients being able to engage and explore nature and the outdoors, and also positive psychological interventions. And what we mean by that could be things like gratitude practices, cognitive behavioural therapy, and acceptance and commitment therapy, which is a type of action-orientated approach. Moving on to social connection. I never feel that we talk enough about social connection, but there's more noise around social connection and feeling connected, and we do have more mounting evidence of the detrimental effects of social isolation, okay? Studies have shown that loneliness can be as harmful to our health as smoking 15 cigarettes a day, levels of alcohol dependence. And also people who are lonely and socially isolated have a higher risk of heart attack and stroke by up to 30%. That's massive. That is huge. And that really is the basis around social prescribers, which are becoming more commonplace, I'm really pleased to say. I think lifestyle medicine also does recognise it's not just about quantity of social connection, but the quality of those connections and relationships. And our final pillar, restorative sleep. We all know how important sleep is. And I know that I don't feel well when I haven't had much sleep, and I'm not always a very nice person either. But there's so much magic going on while we're sleeping. You know, sleep affects our metabolism, our immunity, our cognition, and our mental well-being as well. And the magic that's going on, there's DNA repair and remodeling, our appetite's controlled by ghrelin and leptin secretion. There's other secretion of things like growth hormone and cortisol. ATP synthesis, our memory is encoded while we're sleeping. And also it helps with emotional regulation and also regulation of our gut microbiome. So there's so much going on, and sleep is very, very important. And as Simon was saying before, all of these 6 pillars interact. If one of those pillars is off, it's going to have a knock-on effect to the other pillars. And of course, there's crossover between the pillars as well. So let's go back to Gary, and let's remind ourselves of him. So he is 48, a taxi driver, divorced, and lives alone. And he's quite a typical patient with multi-morbidity. He has the depression, hypertension, dyslipidemia, gout, and erectile dysfunction. And he's on a whole host of kind of pills and medications to make him, to try and help. Okay. Let's see if we can help with a lifestyle medicine approach. Before we go in and tell him all about lifestyle medicine, what we need to do is assess Gary's readiness to change. Now, I'm going to very briefly talk about the trans-theoretical model of behaviour change. This might be something that you all do innately, or you might not need this model. There are other models, but we'll use it as an example today to talk about how he might want to change. Just so you know, this model was developed in the 70s by Prochaska and Di Clemente. And what it does is it helps us tailor our advice and suggestions to where Gary is at in his journey. So very briefly, if we start with pre-contemplation, this is the first stage of behaviour change. So this would be where Gary has never considered lifestyle medicine or making a change in his behaviour, and he might downplay the pros of changing his behaviour. And a change is probably going to be quite far off, quite a few months away. But the next step is contemplation. So Gary's more open to the ideas of lifestyle medicine. He might already have some awareness as well. He might have started looking, and he's going to be more open to discussing the pros and the cons and more likely to make a change over the next few months. Oh, sorry, I'll go back. The preparation phase is what it says, basically. He started planning his change and his journey. He's probably going to start within a few weeks, and he might be even coming to us as clinicians to ask for support about this as well. The next stage is action. So he has started to make that behavioural change. We might just need to give him some reinforcement to keep him on track. The next phase is maintenance. Again, this is when the behaviour becomes more commonplace. Okay, so it's more part of his normal everyday routine, having this behaviour change. Again, sometimes we just need to keep him on track, a bit of confidence as well, and reinforcement. And the final stage I really like because it's relapse, and it's completely normalising the fact that relapse is normal and it happens to everyone. It's what we do after we have a relapse that's really important. And shame is definitely not a healthy way of helping with behaviour change. Just a couple of things before I move on. It's really important to be aware that each of these stages can take time. It might be months and months and months that, Gary takes to go through this whole process. And the other thing to bear in mind is that the model isn't linear. Gary might come to me or come to you at the pre-contemplation phase or even in relapse. So it's our job to kind of work out where he is at the moment. So now we want to work out and offer a stage-matched brief intervention, which is a fancy way of saying, where is Gary at? And we're going to meet him there. So things to remember. If Gary's in the pre-contemplation phase, we might just want to be planting those seeds and raising the awareness of lifestyle medicine. Is he in that preparation phase? We might want to support him with ideas, give him some handouts and resources, or maybe even goal setting with him as well. Or has Gary come to us in relapse? In which case it might be we want to normalise that and maybe just dig around how he feels around the relapse and give him some support there. Things to remember that we want to empower Gary, okay? We want to avoid stigma. We want to focus on well-being and positivity rather the illnesses and the disease. We want to focus on what is going to go well. Always remember that language matters. Try to avoid words. I'm sure you know this already, like fat and overweight. We all have an unconscious bias, and try to mirror the language that Gary is using if that is appropriate. And we might want to consider a lifestyle medicine prescription. Okay, so that might be in the form of something like a SMART goal. For those of you that don't know what a SMART goal is, it's something that's specific, measurable, achievable, realistic, and time-bound. And that might be what we want to prescribe rather than a medicine at this consultation. Okay, I think most of you, if not all of you, are coming from a primary care background, which basically means you already have all the skills that we need to deliver lifestyle medicine. Okay, we need those open questions, those affirmations. We need to reflect and we need to summarize what Gary is telling us. So that's stuff that you can all do incredibly well. But it might be that we want to tweak our consultation skills a little bit and do some motivational interviewing. If anyone doesn't know what motivational interviewing is, it's essentially a way of communicating where we're focusing around goals, where we're specifically highlighting where a patient is now and where they would like to be, but often letting the patient draw their own conclusions from that as well. You have to do active listening and express empathy. You want to support them And as I mentioned, you highlight where they are now, where they want to be, and let them make their own conclusion. Okay, so the person who knows Gary the most is Gary. It might be that I want to control his blood pressure better, and I'm really worried about his cardiovascular disease risk. But that might not be something that Gary's willing to make a behavioural change for, because for Gary, that isn't important at this time. So let's ask Gary, what is the most important thing for you and your health that you would like to address today? And Gary tells us, I would like to feel less tired all the time. Excellent. Okay, we are personalising this now, and we can understand his motivation for change. So our next question could be, which of these factors, and you might be able to show him on a handout or on a piece of paper, which of these factors or areas would you like to focus on at this time to help you reach your goal of having more energy and feeling less tired? And again, we're going to let Gary tell us what he wants to do. We have to remember that Rome wasn't built in a day, and that we're thinking long term. If Gary can make some, changes for his nutrition and the way that he is moving and connecting with others, these could have huge impacts on almost every area of his health. So it is really important that he's aware this isn't a short-term thing. We're keen to help him long-term. And it might be that we want to create one of those SMART goals that I've mentioned already. Now, we might want to do that, leave it with him and follow him up in a couple of months. Or it might be that there's someone that he could see sooner. I've already seen in the chat, some of you have got health and wellbeing coaches. Are there any that work in your primary care network or with you in your practice? Does Gary need talking therapy? Is that a barrier for him in making change at the moment? And never, ever underestimate the importance of peer support. So it might be that for Gary, the way that he can get that is via a social prescriber. So there are lots of additional roles that we can help and utilise with helping Gary make this change. So if you haven't already tried some of this with a patient, hopefully it's given you a couple of ideas that you might be able to try with some patients. What I would recommend is just pick one or two patients and start there and see how you feel. And you will develop your own way of delivering this, of having motivational interviewing, of discussing behavioural change. But I do hear the elephant in the room. I am an NHS GP and I know the pressures that we're under. And a lot of people will feel that we don't have the time to do this. Okay, so it's important that we also think about how we could deliver lifestyle medicine at more of a systems level as well. So there are loads of ways of doing it, and there's no correct way. It's worth trying multiple different ways. And it might be that it wants to stay in the community, just not in primary care. So that could be done with hospital trusts or the voluntary and community sector. Again, public health, the council or the ICS or ICB that want to commission something. But again, it doesn't have to be in primary care in the community. It can be in secondary care. And essentially, I always think, pick your specialty. And I almost can't find a specialty where I think lifestyle medicine couldn't have a positive outcome for patients on their health and well-being. There have been some really beautiful examples in hepatology, looking at fatty liver, in oncology, in rehab and care of the elderly as well. But of course, I have experience at a primary care network level. So I'm just going to take a few minutes to tell you about the service that I co-created. So before I do that, it's important that you understand the area where I work and a bit of the background. So I work in Southeast London in an area called North Lewisham. And our primary care network is really quite big. It's comprised of 9 GP practices and we have 87,000 patients. So it is really big. And of those 87,000 patients, 65% of them fall within the core 20 plus cohorts. And core 20 plus is just a way of kind of trying to pinpoint health inequalities, okay? Of those 87,000, 50% do not speak English as a first language. And there is an 11-year gap in life expectancy between the most deprived and the least deprived. So just to paint the picture of some of the barriers that we have in our community. Excuse me. So in March 2022, I approached our community forum, which was already thriving. It's a place where we have mainly community stakeholders, but also some healthcare stakeholders. that come and meet, and we discuss what's going on and what is important to the community, and they can help shape our services within the PCN. So I approach them with the concept and the idea of lifestyle medicine, and why I felt a lifestyle medicine service may be beneficial in North Lewisham. And from there, we created a co-design working group. Now, if anyone hasn't heard of co-design, it's essentially just designing a service with the people in mind that you're trying to design it for. And it really just stops those top-down decisions that we all see far too often within healthcare. And it really helps with autonomy. The patients and the community feel that they have, created and owned that service, and it helps with engagement as well. So at the forum, we created this working group, and we met 6 times and had 6 workshops. We obviously covered a lot of different things when we were designing the service, but if I pick out some of the key themes so you can see how we created the service, the community told me that they wanted it to be a service that was open to almost everyone. So essentially, just living in North Lewisham, unfortunately, means that you're at higher risk of chronic disease and poorer health outcomes. So we wanted to keep it open to as many people as possible. They wanted it to be non-medical, holistic, personalised, culturally appropriate, which was really important, and also to comprise some group working. So the next part of my journey involved getting PCN buy-in. So I approached the clinical directors and all 9 member practices, and once they were all on board, we agreed to hire our staff using the additional roles reimbursement scheme money, which is secure and in place and luckily not going anywhere. So the staff that work in the service are all health and wellbeing coaches, of which 2 of my staff are also nutritionists as well. So we designed our program to be 12 weeks long, and patients will have 6 one-to-ones with a health and wellbeing coach where they can do personalised goal setting, and they have a nice long consultation. And then they also have 4 to 6 group consultations. And in those group consultations, they'll cover each pillar of lifestyle medicine and also have the benefits of peer support as well. So at the moment, we are currently in the data gathering phase. However, I am really excited that the early data we've seen has already shown me statistically significant improvements in lots of different things, including validated wellbeing scores, sleep length and quality, the amount of physical activity that our patients are doing, how connected to others they felt, improvements in their mental wellbeing, and also the one I like the best, how in control those patients and individuals felt of their own health journey. So far, my staff have seen around 200 patients, and we already have another 200 on our waiting list. So I'm hoping that I can share some of our insights and data at another time in the near future with you all. We have also from this commissioned a lifestyle medicine diabetes service, which is the exact same service, just focusing a bit more on the specifics around patients living with diabetes. And that early data has shown incredible improvements in HbA1c. So I think I'm going to hand back to Simon now to try and draw a bit of a conclusion from what we've been going through.
Fantastic, Camille. Absolutely inspirational on how you find the time and energy to do that on top of your normal NHS work. I think is a real inspiration to us all. Absolutely fantastic. So just to wrap up the conclusions from the evening, and then we'll go back to Will and see what's happening on the chat and have a bit more discussion with Camille. We need to change the model. We need to change the way that we're thinking and to think more upstream at the root causes, at the determinants of all these chronic diseases that we're seeing, particularly for our patients living in deprived areas with multiple risk factors who are losing years and years of health and life. Lifestyle medicine is not wacky, it's not fluffy, it's the use of evidence-based lifestyle therapeutic interventions which have the potential to treat and often reverse chronic disease, and it's got a strong evidence base to support it. It's based on these 3 principles of the socioeconomic determinants of health, skills to support people to make sustainable changes, understanding, for example, the cycle of change, using our core GP consulting skills, use of brief interventions. Remember, making every consultation count, and motivational interviewing. Techniques and knowledge of those 6 pillars of lifestyle medicine. And it's effective and deliverable in the NHS at both an individual and systems level. So let's not give up. Let's not think, we can't possibly do this, and just keep on endlessly prescribing without at least giving patients that opportunity to make that change, giving patients that opportunity to have that discussion with you that they probably really want to have, and they probably want to have that support. Before we go back to Will, just a quick mention on some of our live and on-demand courses that are upcoming. If you're new to us at MB Medical, we've got a whole range of one-day courses, our classic GP update course, urgent care, women's health, and we've got lots of half-day courses as well, dermatology, managing obesity and overweight, abnormal bloods course. All of these you can find information on our website. And we've got 3 brand new half-day courses which are just launching this spring and summer. Men's health for primary care, palliative and end-of-life care course for primary care, and our primary care cardiology and ECG courses, all of which are available live and on demand. And brand new, our new and half-day courses are just at £120 each, and you can see them either live or on demand, or you can get all of that as part of an MB Plus subscription. Okay, back over to you, Will. What's been happening on the chat?
Well, yeah, loads of buzz on the chat here, Simon. I think people are really inspired by your program in North Lewisham there, Camille, particularly this model of co-design, it not being top down, but co-developed with the community. I think that makes it much more sustainable and really meets the needs of that community. And with that in mind, there's a really interesting question here. Let me just bring this one up about how you. This is from Alexandra. Thanks for this, Alexandra. How do you get? We've talked about achieving buy-in from patients, but how do you get the buy-in of the rest of the practice team, or indeed your PCN or the other stakeholders involved in bringing about an initiative like you have? What are your thoughts on that, Camille? How did you achieve that to make this a success?
I think it is actually really difficult. I think getting stakeholder buy-in, healthcare stakeholder buy-in, is actually the hardest thing. The patients I speak to are all over this. They are fed up of, rattling when they get shaken from all the pills they're taking. And all the myths that Simon went through today are the things that they throw at me every time, oh, it's fluffy, what's the evidence, etc. So when I approached this, I had a SPIN fellowship at the time, which is kind of a portfolio GP kind of session I used to get paid for to have a bit of time to do this. And I approached the PCN, I spoke to them, I showed them some evidence, I showed them some some other examples of how it could work. But I think the reason there was buy-in is because I wasn't asking for money. The funding was already there for the staff, and it's such a beautiful model to use with health and wellbeing coaches. So I wasn't asking for too much. It was money that was there. And so they felt like it was worth a try. I think if you really want to get buy-in, though, you might want to consider, trying to help with QOF, trying to help with the PCN DES. So do they need to target hypertensive patients? Do they need to work on lipid lowering? It was difficult because this had been co-designed to be essentially for everyone with very little exclusion criteria. But those are really nifty ways of helping get buy-in, basically.
And on that theme, Camille, a couple of delegates, including Lucy, has asked around the mismatch between our goals with a QOF and actually what patients really need in terms of healthy lifestyles and the right advice in the right moment for them that's matched to their stage of behavior change, etc. If you got any insights in how we can reconcile that mismatch and with the project you did, was that mapped against QOF, or with QOF feature in the design and delivery of that service at all?
I think, quaff is probably a wider systems issue, and you're absolutely right. You've got the money in the right place there. Quaff, like you've said, is it always target doing the things in the best interest of the patient? When we're doing all these projects, you can see the benefits. Sometimes we're not so sure. Remind me of the second part of your question, Will. You were saying,
yeah, how patients, how clinicians can. Oh, sorry. The second part was around whether you incorporated quaff into your service.
Apologies, my mind went blank for a sec. Yes. So what we did, we made it open to everyone, but we did try to target two groups. So underserved community, so people who didn't access or make the most of primary care for multiple reasons, but also cardiovascular disease. So anyone could self-refer or be referred in, but we might send some batch messaging trying to help with cardiovascular disease. So that was looking at the DES and also the quaff for blood pressure and lipid targets as well.
Yeah, and I remember you saying, Camille, sorry to interrupt, Will, that you don't think people be interested to know you don't actually work as a clinician in the lifestyle medicine service yourself. And just tell us a little bit about.
That's exactly right. So I felt a bit upset when I went to the community and they said, no, we don't want it to be medical. But I was very quickly brought on, and it makes it a much more sustainable model. So you don't need to pay a GP or a clinician to work in this setting. Yeah, I don't work in it. I'm simply the clinical lead for it. So I might meet with the coaches and I do a bit of service management and the evaluation. And that's my only role within this. And my coaches are absolutely superb. They work really, really well. And it seems to be going really well. And they enjoy it. And the feedback is just really, really positive.
Brilliant. Yes. Shrivanthi says, truly inspiring and insightful. Great question here. This has come up from a few different delegates. One of the 6 pillars of lifestyle medicine is nutrition, and perhaps this is the most controversial of all of them. And I think there's a bit of confusion here around what should we be recommending to patients in terms of preferred diets. What is the best diet? Is it plant-based? Is it low carb? Is it a Mediterranean diet, Camille? Is there the kind of the best diet, or does it really depend on the individual patient? Your thoughts, please.
Exactly that. I'm going to throw it back at you, and it totally depends on the person in front of you. So the evidence with lifestyle medicine, it pulls all of that data from all of those studies together, and it does illustrate some of the benefits, and there are benefits in different conditions. Simon's already mentioned the DASH diet for hypertension, the portfolio diet for lowering lipids. But the key themes across lifestyle medicine is that we want it to be whole food. So we're avoiding that ultra-processed food and predominantly plant-based. But it might be the person in front of you is all up for trying intermittent fasting. It might be the person in front of you is very much an omnivore. So we're trying to add grains, add fiber into their diet. I tend to avoid using a specific diet. Some people really like it. I tend to go for more kind of whole foods, eat the rainbow, think what you can add that's positive rather than a specific diet, because they do tend to be fads and they're harder to stick to for patients. But it depends who's sat in front of you.
And what about, Camille, what about the greater cost of eating healthy whole food diets, given this huge issue with socioeconomic deprivation? And it's certainly, I've got lots of patients and families that just sort of feed ultra-processed food to their family all the time and say that's what they can afford. And when I've tried to have these discussions before the sort of cost comes up, how do you address those issues?
It's a really interesting thing, and it's something I feel quite passionate about. And I do think the wider problem is more political, more the food giants and the way they monopolize things, and looking at ultra-processed foods and the way that things are marketed. However, it doesn't mean that we can't help patients with change. There are some really lovely low-cost whole foods and recipes and things that people can try. As I mentioned, Jack Monroe before. But I think just making people aware. I always tell them about our local market in Deptford and how you can buy a whole bowl of fruit or a whole bowl of vegetables for £1. It depends what you have in the local area. And it might be you have a social prescriber or someone who knows the locality better and knows where the cultural shops are, knows the prices of the market. But it is very difficult. It is a very difficult thing that's probably bigger than us and our patients. But I'm hoping there will be change.
It's very interesting. There was an article in GP Online published last month on a scheme where they actually gave patients vouchers to get fruit and veg, £8 vouchers, and they gave them these vouchers over 8 months, and 80% of participants by the end were eating fruit and veg 5 portions a day compared to 28% beforehand, and 40% reduction in GP visits in patients who took part in the scheme. So another example of a scheme like yours, Camille, but sometimes when you put a bit of money behind it, it's amazing what an impact that can have, these things.
Absolutely.
I've just got two more very brief questions. These are real pain points for our audience, Camille, that I'm hoping you can help them with. One is a couple of sessional GPs on here. Rue is one of them, who are asking, for those who are locums and sessional, who perhaps don't have that continuity of care that, say, partners and salarieds benefit from, how can they start to unlock some of these conversations with patients around behavior change? And the second part, and I'm sorry, I'm going to lump it into one just in the interest of time. A lot of people still saying, come on, how am I going to do this in the 10 minutes that I've got? So maybe perhaps you could leave people with just a couple of nuggets on, how can they do something meaningful with the very limited time that they have?
Yeah. It is difficult. We all know continuity of care is ideal. It's the gold standard. But I don't think that should be a barrier. It's those open questions. Have you heard of lifestyle medicine? Have you thought of any lifestyle changes? What is the most important thing for you at this moment? How would you like me to help you get there? It might not be possible with, it's definitely not something you can do with every patient in your clinic, I find. I think sometimes you will find the right patient for it. I love doing it with my mental health patients. I think it works incredibly well, and almost none of them opt for the SSRI. They all want to try the behavioural change, and I follow them up as appropriate, etc. It's difficult, but I wouldn't want to think being a locum would stop you. You can still open those conversations. You can still hand out those resources, point them at those podcasts, and if they want to learn more, where they can find more information. And I always document it. My colleagues may think I'm mad, but I'll always say something about lifestyle medicine and how we spoke about fibre and nutrition, or something in the consultation skills, in the consultation notes. And the other thing about how you do it in 10 minutes, it's hard. And I do run late sometimes. But it is doable. It really is doable. I'm being honest. I should say it's totally fine and you can do it with everyone, but it is doable. And you pick your patients and you build your confidence. And it is those kind of 2 questions to find out where they are right now and how open they are to finding out about behavioural change. And there is kind of this sweeping new younger generation who have done a lot of lifestyle medicine already, and they all meditate and they are vegan and they do it. But it's finding a bit more, and you'd be surprised how open patients are to it. So I implore you to try. Don't hate me if you run late, and build your confidence.
That's absolutely fantastic, Camille. Thank you so much. That's real inspiration to us all to try and start bringing this into our practice tomorrow. So you've been a fantastic inspiration. Thank you very much for sort of sharing your experience with us. And if you out there would like more on lifestyle medicine, a more fuller and more sort of detailed course for us to produce on lifestyle medicine with Camille, then do let us know. Do get in touch. And then that's something which we would look at sort of introducing later in the year. Many, many thanks as well to Will in Exeter. Will, you've done a fantastic job as always on the chat. So many, many thanks to you. And if you have any further questions that come out of the webinar after tonight, do feel free to email Will or myself, simon@nbmedical.com, will@nbmedical.com as well. We'd really appreciate or value if you get a moment to just spend a minute or so just filling out some feedback so that we can improve our webinars, make them as useful and as relevant for you as possible. A feedback form will pop up as in a second as soon as the webinar finishes. But that's it. Thank you very much for watching. We've loved having you with us this evening. Thank you very much to Camille. Thanks a lot to Will, to Daniel up in Newcastle, making sure all the IT works as well. But above all, thank you to you for tuning in and being with us tonight. And best of luck tomorrow back in the practice, starting your new journey and trying to practice some lifestyle medicine. Thanks again, and we hope to see you all again soon.